You guys want to get started? So welcome everyone who's with us today. My name is Jacob Hall. I'm one of the PGY4s at UNC and one of the co-moderators today for our high-risk prostate cancer session.
And I'm Mukarsha. I will also be co-moderating today. I'm a PGY5 at Tufts. So if it's okay, if we can go ahead and have our panelists introduce themselves. We'll actually begin with Dr. Johnson, and we'll just kind of go left to right here, if that's okay.
Yeah, great. My name's Skylar Johnson. I'm a GU radiation oncologist at the Huntsman Cancer Institute in the University of Utah in Salt Lake City. I've been here for about 3 years now and starting into my 4th year. So I'm not so far removed from residency that I've forgot how little I once knew. And I'm also reminded often how little I know even now. So I appreciate this opportunity to teach and learn.
I guess that's me, Neil. My name is Neil Desai. I'm a radiation oncologist at UT Southwestern. I guess getting it out there now in years, graduated 2015, I did my training up in New York, Memorial Sloan Kettering, and it's just enjoying the world we're in. GU is a great space to do work in. People are happy. Surgeons tolerate us. It's a great day.
My name is Alexandra Sokolova. I'm a medical oncologist at Oregon Health Science University in Portland, and I specialize in prostate cancer. And I'll be happy to kind of get into the radiation oncology world and talk about systemic options. Happy to be here today.
Hi, I'm Dan Lin. I'm the token surgeon probably on the call today, or sacrificial surgeon, I'm not sure which. So happy, and thanks for including me. Neil and I trained at the same place, Memorial, but I was at the time of Steve Leibel, so it was like 20 years ago, a long time ago. That's a really old picture of me on the screen, so still have black hair. But really appreciate the opportunity, and again, like everybody, anxious to learn.
At least you still have hair, you know. Some of us aren't so lucky.
Great. So I think I will let Jacob kind of move forward with the slides. I just wanted to make one comment for all the panelists, for all the attendees, to please, if you do have a question, we try to keep this as interactive as we possibly can. But if you do send a question, try to address it to everyone so that we can all see it and reply in the chat. We will go from there. All right.
That sounds great. Let's get started. So our first case will be presented by Dr. Sokolova.
So this is a case of a high-risk localized prostate cancer. We have a 67-year-old gentleman presenting with a Gleason 4+5 with a PCO44 diagnosis. MRI showed evidence of syncovascular extension, extracapsular extension, and on a CT scan, he had a positive lymph nodes. So the first question we have today is, if this patient chooses to go for radiation therapy, what systemic option adjuvantly would you recommend? Should we do just ADT for 18, 24, 6 months? Should we do ADT and abiraterone for 2 years? Or should we do abiraterone bicalutamide for 2 years? And so it looks like we have 2 options that folks went for, is ADT plus abiraterone for 2 years or ADT for 2 years only. So let's talk a little about the data for the ADT plus abiraterone for 2 years, because until fall of last year, ADT for 2 years was the standard of care. And we can advance to the next slide, please. And on ESMO of 2021, the STAMPEDE analysis was presented that I think is shifting our standard of care, and we offering ADT plus abiraterone for 2 years for very high-risk patients. So STAMPEDE, a lot of you probably familiar with it, is multi-arm, multi-stage trial. And this data, this analysis, is part of two separate comparisons. And it randomized men that had M0 disease with either node positive or high risk node negative, which had at least two. So T3 or T4, PSA more than 40, inclusion 8, 9, or 10. So kind of looking into this very high risk subgroup of patients. It also included a smaller group of patients with biochemical relapse, again, either node positive or PSA more than 4 and PSA double in time less than 6 months, or PSA 20 and above. And these patients were randomized to either adjuvant ADT or ADT plus abiraterone. Next slide, please. And as I said, this is part of two separate analyses. So they tried to answer two questions. The first question was, is addition of abiraterone to ADT for 2 years is better than ADT alone? And the second question they ask is, addition of enzalutamide to abiraterone is better than ADT plus abiraterone alone? And I'll spare you details of the second part, but the answer is well, that enzalutamide didn't show any additional benefit. So they kind of combined everyone who did ADT plus abiraterone in their analysis when they were presenting data. So it was kind of group of patients, ADT alone or ADT plus abiraterone plus minus enzalutamide. Next slide, please. And addition of abiraterone for 2 years in adjuvant setting after radiation therapy did show metastasis-free survival benefit. Metastasis-free survival was 69 versus 82%. Next slide, please. And it also showed a survival benefit, 77 versus 86%. So it's about 10% benefit with addition of those 2 years. Next slide, please. When you think about side effects, the biggest addition of side effects was in the abiraterone plus enzalutamide group, and you can see it on the right. When you look about ADT alone or ADT plus abiraterone, the difference is not as significant, and the biggest difference was in hypertension and transaminitis, which are common side effects of abiraterone and were to be expected. Next slide, please. So this kind of ends the point on STAMPEDE and the data to recommend ADT plus abiraterone. In clinic, I don't recommend it to all patients with high risk or all of them who go for radiation therapy, but if they do qualify this kind of very high risk criteria that use STAMPEDE, I do talk with my patients about it because I think there is added benefit, and we discuss the data. And some of them say, well, I don't care about this 10% added, I don't want to be on extra pill. And that's a valid choice for them. But a lot of patients, when they see the survival benefit, do choose to add abiraterone. But as someone who is passionate about prostate cancer genetics and germline testing, I couldn't lose the opportunity to talk to you guys about the germline testing. So this is a high-risk patient with localized disease. Do we need to send him for germline testing or not? Does he meet the NCCN criteria? And so it's 80-20. Majority of you thought that he does meet NCCN criteria for testing. And you were right. Next slide, please. So NCCN guidelines recommend germline testing, and germline means hereditary cancer syndromes. So it's a live or a blood test to see if patients were born with mutations that increase their risk of prostate cancer. And the current guidelines is everyone with high-risk disease. So you don't even have to be very high risk. So everyone with high-risk disease. So T3 above, glycine grade 4, PSA more than 20, lymph node positive, qualifies for germline testing. Everyone with metastatic disease, no matter if castration sensitive or castration resistant. Everyone who meets family history criteria. So you hear like breast, ovarian cancer in the family, prostate cancer in the family, Leach cancer syndromes also qualify. And we look for hereditary breast and ovarian cancer genes, which is BRCA1, 2, ATM, PALB2, CHEK2, and Lynch cancer syndromes, MLH1, MSH2, MSH6, PMS2. So the testing in localized setting is not necessarily changing what we do with these patients now. I think in the future it will. We probably will have some data in kind of adjuvant, neoadjuvant setting for these patient populations. There was a lot of trials happening, so they could become candidates for a clinical trial. But it is very meaningful for patient potentially in the future, if they were to relapse and develop metastatic disease, that would be eligible for targeted PARP inhibitors and platinum chemotherapy. It's also informative prognosis. We know that patients who do have BRCA1/2 mutations have a higher kind of chance of having aggressive phenotype. They usually have shorter metastasis-free survival. They have usually worse overall survival. And it's also meaningful for their family, for both daughters and sons, brothers and sisters, because if our patient carries a mutation, 50-50 chance that their family members will carry the mutation. And if we identified in a patient, we need to test their family. So kind of it could help save lives of their loved ones in the family. So it's kind of a threefold. We talk about prognosis, we talk about potential targeted treatments options in the future, not at this point, or potential clinical trials now, and a family risk factors. And I think we can skip the additional slide now and kind of transition to the questions.
I put a, Sasha, I put a couple of questions in the chat, I think that are maybe relevant for the audience. I mean, the first one is, do you recommend formal genetic counseling, or do you do it yourself, or do we do it ourselves? Should we do it ourselves? And then is there a specified platform that you recommend? I mean, we have our own here at the University of Washington platforms that are local, but also there are national platforms. And then lastly, do you do any somatic testing?
Thank you. Very, very important question. So I'll start with the million-dollar question. Do we do pre-test counseling or not? So the pre-test counseling came from a time where we had mutations that could affect quality of life significantly, like metabolic mutations, and no, you could not have done anything with that. So talking to genetic counselor, like you might find out about this life-threatening mutation, which you wouldn't know about, like, do you want to do it or not? And that's kind of how our genetic counseling world built in. And so the standard now is you meet with genetic counselor for an hour to talk about pros and cons, and then you do the testing, and then you meet with them after to discuss the results. When we talk about germline testing in prostate cancer, I think the meaning of pre-test counseling is much less significant than it is with some other diseases. And because we have trouble with access to genetic counseling, I think that moving toward where it's provider initiated, when you as radiation oncologist, when you see your high risk patients, you say, hey, you qualify, like this is what we can do. Or we as medical oncologists, when we see them for ADT, we talk to them about it. I think that's where we probably moving forward at our institution. We still kind of using this old pre-test counseling, post-test counseling model, but we're all kind of trying to be creative and brainstorming how that would change. There is an option to get tested on a study, and there are several studies which are patient initiated, and all you have to do is kind of give the information to the patient. One of them is led by Dr. Heather Chang, University of Washington. It's called Gentlemen, and it's for all men with metastatic prostate cancer. And there is a new initiative led by Heather Chang and Dr. Peller. It's called Promise. And this is for anyone with prostate cancer. So any patient that has diagnosis of prostate cancer, and they just go online, they fill out some questionnaires, and then the saliva kit is sent to their home. They spit in the tube, they send it back, and then genetic counselor calls them. So there is no insurance billing. There is nothing for you have to do other than just kind of giving them the information. And I'll be happy to circulate the link to the study after this call. Second question was which platform to use. When we talk about germline testing, I don't think it really matters, because most of the kind of commercially available or homegrown germline panels would include the genes that we're interested in, which is kind of HBOC and Leach syndrome. So I think the platform for germline is not as important. I think there is more nuances in somatic panels. And this kind of leads into the last question, do we recommend somatic testing for high-risk prostate cancer? Currently, NCCN guidelines kind of don't say that it's recommended. There is no direct treatment implication at that time, unless we look into clinical trials, especially adjuvant, neoadjuvant clinical trials. So I would say that right now for the high-risk disease, it's controversial whether or not to do somatic. I personally don't do it unless I have a clinical trial that I'm kind of screening patients for, because I'm not necessarily going to be using this information for their treatment. And hopefully at least half of them wouldn't need this information in the past because they would be kind of cured or kind of not develop metastasis later on. And Dr. Lin just sent the link to the Promise website. I appreciate that. So I would encourage all of you to save it. It's very easy to kind of just tell your patient, hey, like you need to get your testing done, could be meaningful for your family, could save lives of your daughters and sisters. This is a link. You just have to like put some information in and send the test in.
And I don't believe the attendings can see the links. So I'm just gonna plug in here. The link is actually pretty straightforward. It's just prostatecancerpromise.org. So again, that's prostatecancerpromise.org.
So I had a quick question. Our medical oncologists, when patients are treated in this setting, kind of per the Stampede protocol, they kind of go by the book in terms of the duration of the ADT, and they will do like a full 3 years. And I will, I often try to encourage a little bit less because it's sometimes can be a little bit of a hard sell when somebody can have just ADT alone, maybe for 2 years, but then we add abiraterone, they're getting abiraterone for 2 years and then hormone therapy or for 3 years. And so I'm just curious if that's something that your group has talked about or how you approach those conversations.
Thank you for this question. It is true that in Stampede, they used 3 years of ADT and 2 years of abiraterone. And we've kind of interpreted with a grain of salt because as we know, the data for adjuvant ADT is somewhere between 18 and 36 months, and there's data for kind of all of it. And we just use a middle ground of 24 clinically, and that's what we've been doing, and we have not changed that. So when we do talk to our patients, we do 2 years of both ADT and abiraterone. This is not by the book. This is kind of using our judgment, but I agree with you. I think it's a harder sell, not only tell, well, you have to be on a pill, but also you have to be on a shots for another year. I think that's the harder sell.
Yeah, thank you.
Do we have any other questions before we move on to the next case?
I guess a question I would have for everyone is, as we're doing more of this on therapy toxicities, a lot of these patients are starting abiraterone during radiation or soon before. What is our role in monitoring blood pressure and electrolytes and things like that? How can we integrate with medical oncology teams?
Very good question. I think it really depends on kind of how this is set up at each institution. I know at some institution, radiation oncologists administer ADT, and other places they go straight to medical oncologists. The way we have it developed is medical oncologists manage it. And so we would be kind of monitoring the electrolytes and LFTs. And we have a set kind of a protocol. Okay, you check blood work at 2, 4, 6, 12 weeks, and then kind of what to do with that. But with abiraterone, you do have to monitor CMPs. Per protocol, it's every 2 weeks for the first 3 months and monthly afterwards. I think it's a little excessive, so a lot of institutions have been modifying it, but for the first 3 months, it requires more intense monitoring, maybe every 2 to 4 weeks in the first 3 months. And then if it's normal, we go to every 3 months. If it's abnormal, kind of continue monitoring it. Most of the liver toxicities were around 6 to 8 weeks in the study. So that's why it's kind of the more crucial to look at the beginning. Hypertension, and honestly, anything cardiac related. So if patient develops edema or palpitations or anything kind of cardiovascular related, you start worrying because abiraterone can make all of those things worse. So as your radiation oncologist, you see someone on abiraterone and you see their LFTs elevated or their blood pressure or any like other symptoms, at least notify their medical oncologist, their primary care doctor. So we're kind of looking for these things.
It's funny that you should even ask that question, and it's only because I just recently had a patient who had basically a rip-roaring high blood pressure when I was seeing him for an OTV, and as it turns out, he'd not been taking his prednisone regularly. So, you know, abiraterone, you know, based on how it works, you know, with glucocorticoids, it's necessary to obviously be taking prednisone to avoid that. So it's a nice opportunity, obviously, for us to see patients on treatment and to at least monitor for some of those side effects.
That is a very good point. Usually when I talk to my patients about abiraterone, I tell them, like, you can never stop prednisone while you're taking it. It might kill you. Like, if you ever stop taking prednisone, you have to stop taking abiraterone, otherwise you'll die. Because those kind of hyperkalemia, arrhythmias could be an issue. And when patients have like hyperkalemias, elevated blood pressure, we do ask, well, are you taking your prednisone the way you're supposed to?
And that's a really good teaching point. I don't know whether on your radiation oncology boards that you test that. On urology, we do. We test the enzyme and the fact that it can get mineralocorticoid excess and hyperkalemia and hypertension and so forth. But it's a good teaching point for the house staff on the call here.
All right. Yeah, I totally agree. I think that's something that's very important. I'm not, to my knowledge, I don't know if it's on radiation oncology boards really, but something that we should definitely be keeping track of for sure. Well, if we don't have any other questions, we can move on to the next case, which I believe is for Dr. Desai.
Thank you. So in this case, you can go to the next slide. Thank you. You know, in this case, you know, we're going to turn the page a little bit to from talking about optimizing intensification to talking about which patients can even tolerate the intensifications we commonly talk about. We're always debating combination brachy, boost, and things like that. So this gentleman is 71 years old with a history of insulin-dependent diabetes, but well managed here, with substantial obstructive urinary symptoms on finasteride, with significant family history of prostate cancer, rising PSA, bulging nodule, and large gland, and gets an MRI showing this quite substantially enlarged prostate with PIRADS 4 lesion on the right side, no extraprostatic extension grossly, but borderline. And so the first question I would ask here in looking at this kind of MRI is, you know, this bulging capsule, early EP indeterminate, we're seeing all sorts of different discussions of what you call this. Do you call this, you know, clinically EPE conferring high risk in your practice? Sure, when the poll results will pop up. Yeah, so it seems like a lot of people do, and you know, I think this is an area of debate and question. I maybe should have a slide on this. Alfonso Gutierrez Arteaga has a nice paper on this, looking at what does MRI defined extraprostatic extension mean and confer in terms of prognosis. Clearly, gross extraprostatic extension MRI is high risk and feature in radiation cohorts as well as other cohorts. But borderline, I think we'd be careful about not stage migrating patients. If you're not feeling it, this is not the same as locally advanced T3 disease on which high risk classifications are based back in the 1990s. So I honestly myself, I don't know what other people feel, would say a bulging capsule without gross extracapsular extension, it would not qualify as a high risk feature in itself, to my mind. But we'll make it so in this case, is because we're talking about high risk prostate cancer. And so then moving to the next, and you know, we're looking at this. Sorry, go back to 1 second. The other MRI, you know, in this workup, what are we getting for the multiparametric MRI? We're looking at anatomy, of course. There's a very large median lobe here, or sorry, median zone. There's not a huge amount of invagination to the bladder neck on the sagittal views, but certainly the obstructive pathology here is clearly correlating to the imaging. Moreover, in terms of disease assessment, there's concordance of the diagnosis, or I guess we'll get to this, but the question will be when we do biopsies, is there concordance of your biopsy yield to where you find dominant disease? In terms of diffusion weighted imaging, you see on the bottom left of the screen with this ADC map restricted lesion correlated to low T2 lesion. And now we can go next slide. In terms of workup, this patient got a biopsy template with lesion-directed cores that on which the latter found a gray group 4 lesion conferring high-risk disease. Standard conventional imaging was negative. There was no access to PET for the sake of this case. And this certainly patient-reported quality of life questionnaires are significantly elevated. IPSS 21 on max alpha blockade, Cialis, and significant post-void residuals, which we can talk about. I don't know who does this in their practice or not, but we will do it in a case like this. Decider genomic risk is high here. And so the question I would put now, the next poll question is, what is your local modality of choice? Surgery, radiation, or maybe an outlet procedure be followed by radiation. I think we have a 5 count here. There's only one surgeon here, so. I gotta tell Aditya Bergardi about this. So excellent. So yeah, there's actually pretty even a split of things. Some people will go straight to radiation. Some folks will do outlet procedure, and Dr. Lin will do surgery. Next to the next, I'll be curious to hear your thoughts on surgical challenges in this case as well. But next slide. And so, I think before we move to plan for treatment, I would say really, in my strong opinion, this needs optimization before therapy. Patients already maximized out on alpha blockade, has significant obstructive lower urinary tract symptoms and the gland anatomy that matches. And this would predict for worse outcomes, certainly with radiation in regards to urinary quality of life, due to the obstructive symptoms at least. And I would argue, at least when we discuss with our surgeons, and I wish I had better data for this, but probably some worse outcomes after surgery as well in terms of incontinence risk. And furthermore, the neurovascular bundles are fairly stretched out as well in these cases, or so I'm told. But again, I want to hear from Dr. Lin on what the challenges are for a larger prostate surgery. And so for outlet procedures, there's of course TURP, green light. There's lots of UroLift things. I think UroLift would probably fail in this kind of case. The lateral lobes are so substantial, you're not going to get traction. Hold up and side reduction ADT. I don't think ADT is going to do the trick here in terms of reducing the gland enough. Certainly that transition zone will not be as responsive to side reduction as the peripheral zone will be. And so our choice in this case, at least where I am, will be a simple prostatectomy followed by radiation. And so now going to the next slide, this is a little bit off the beaten track, but what is robot assisted simple prostatectomy? Well, you're going into the bladder dome and essentially enucleating the adenoma of the median lobe. And this will have substantially less erectile dysfunction and stress and incontinence risk as compared to radical prostatectomy, but is not oncologic, of course, in terms of resection. So this patient had this done, 72 grams of an adenoma came out with no cancer inside it. This is important to me because if there is cancer inside it, then you got to be worried about what's left in the bladder neck and the defect you left there. But we went ahead and did a spacer gel after this and getting a much nicer anatomy now. You can see on the right here in terms of radiating mainly prostate gland and maybe not having to push as much into bladder neck, but certainly having less obstructive gland in the way for treatment. And so next slide. What about the waiting period? We're not going to do a simple prostatectomy and go straight to surgery or radiation. I mean, just like with TURP, I think most of us, based upon no data at all, but probably good principles of healing, at least wait about 2-3 months after the surgery to go to radiation. We temporize with hormonal therapy during this time. I think sometimes we'll hear from people saying, well, extended neoadjuvant hormone therapy is bad, right? Dan Spratt put out a good paper looking at an intermediate risk setting for short-term hormonal therapy that you really want to stack hormone therapy, at least maybe favoring the adjunct side and not the neoadjuvant side. Certainly studies have not shown a benefit from extended neoadjuvant hormone therapy. But this is not, I think, and he's been very clear in that paper, does not apply necessarily to long-term hormone therapy where we're trying to side reduce or temporize to get to radiation. This would be an appropriate use in the setting where this patient will be getting long-term hormones if they proceed with radiation. So next slide. In terms of the radiation plan, this is really data's free zone. We're hopefully trying to get a data set going on this, published in the next year or two once we get more maturity of our patients. But we chose moderate hyperfractionation for this patient. Again, 2 to 3 months after healing of the simple prostatectomy. Did 42 and 20 of the nodes. Again, not a lot of high level data for that, but 20 fractions to me, based on British data for whole bladder treatments as well as prostate treatments, seems spot on and fairly tolerable. And 18 months of hormone therapy is what we selected And again, there's unclear in this case as to whether they'd benefit from abiraterone. Certainly not a Stampede eligible or criteria satisfying patient. Of course, you can also consider GU009 for intensification of hormonal therapy, which is a separate question, I think, answered by the other case presenters better than I. Next slide. In terms of radiation plan intensity, though, I think we initially started this with a question of challenging us, saying we constantly debate over the optimal intensification of care for our patients, as if everyone can get surgery followed by post-op radiation, as if everyone can get combination brachytherapy boost with radiation. But the reality is there's a substantial number of men with these non-ideal cases. And what do we do to intensify their therapy beyond systemic intensification? I think the FLAME trial by Linda Kirschmeyer and the Dutch group is, I think, a very nice bone being thrown in our direction regarding maybe not the entire prostate needs to be boosted. In this gentleman with that dominant lesion in the right posterior gland that yielded grade group 4, clearly patterns of relapse analyses have shown that that will be the area of most dominant relapse after radiation. And so perhaps a focal SIB to that dominant lesion will be a lot safer than intensifying the whole gland in a case like this with or without that prostatectomy. Indeed, the whole point of FLAME, the randomized phase 3 trial, was that there's a biochemical control benefit without increase in patient-reported or physician-reported toxicities as compared to brachytherapy boost. And so next slide. In this regard, for this radiation plan, the principles here are, clearly this was not a FLAME regimen. A FLAME was a sort of mainly essentially conventionally fractionated approach. In this case, we're hyperfractionating. Nonetheless, we basically applied the same principles, doing 60 gray of the prostate, and I took the lesion to 70 gray and basically applied the same constraints as if basically telling the symmetrist and applying constraints such that as if you were not doing an SIB. Urethra, rectum, and bladder in this case be constrained to max doses that you would get normally for an IMRT plan. 107% hotspots would be reasonable. And so this is something we do quite commonly here. We snuck this into the GU10 protocol for the NRG study that's ongoing. So you could do it. There's lots of nice tables that are not made up, but we abstracted this and extrapolated from other dose constraints for SIBs. And this is what we did for this patient, and just kind of concentrate on being very careful about setups every day. And lining up that SIB area away from the defect. Next slide. So I think the challenging aspects of this case, I'll turn to discussion now, is how do you optimize a patient like this for quote unquote optimal therapy in a non-optimal setting? How do you widen a population who may benefit from selective intensification of therapies that cannot get brachytherapy boost necessarily? And what do you do for imaging fusion? So we want to do SIB, but how good are you for MRI fusions? Is MRI going to be sufficient? Maybe PET PSMA will be better. There's a German phase 3 trial going on using that. What's the right dose for SIB? I think keeping things safe by being robust with your fusions and by talking to your therapist in terms of what they think is setting up well is very important before you start doing this. But I at least favor something off the board in a patient like this, who otherwise would be, I think, served with conventional radiation approaches, but maybe we can do a little better. So I want to turn this over to the panel for discussion and of course, invite questions regarding this. Maybe I'll ask Dr. Lin, what do you think about surgery for this guy?
Yeah, I can start there just to say, I think that, again, he's kind of stacked against it. 71 years old. He's got diabetes, insulin-dependent diabetes, mellitus. He's not that healthy. I mean, I could say that he's very borderline, yet he has bladder outlet obstructive symptoms. I mean, his IPSS, I think, was over 20, and we would get rid of that. Of course, we might trade incontinence, of course. I don't think when one looks at the data from high volume centers with high quality surgery that the rates of incontinence are that much difference with large glands than small glands or normal sized glands. So I don't think, at least I don't quote my patients with 100-gram glands that they necessarily are going to have much higher incontinence rates. I think anecdotally they might be a slightly higher, but not terribly higher. I think it is certainly an initial management, knowing that they might need post-op radiation as well. I have no problems at all with some sort of outlet procedure, like in this case, a RASP or a TURP, followed by radiation. I think that's a very reasonable option. There have been, as you noted, this idea of neoadjuvant downsizing or cytoreduction, and men do have some relief. I mean, they do. He might drop his IPSS down in the teens or maybe even mid-teens or low teens because of 30-40% reduction in prostate size, and a lot of it being the transition zone. that was removed in the robotic simple. But again, we always now wonder, is that throwing all these cells into G0 and then the radiation doesn't have an effect and so forth? That's the theory behind not having it concurrent and doing it adjuvantly on a hormonal level. But I think that he's a surgical candidate, kind of. I mean, borderline. I think that I agree he was sort of stacked against. If he was 5 or 10 years younger and a little healthier, I think he certainly would. And we've done that at quite a bit. I have some questions though. I mean, I think it's good for discussion, is like some things like, is there an IPSS cutoff that you in your field have with regards to not like a no-go for radiation or brachy? I know that what our people here do. And then the other question is, do we need a decipher on all these guys? Because the one was obtained on this, and what does the panel think on that?
Yeah, so I'll kick it off. I think in regards to IPSS, I don't think there's a cap IPSS score I have for treatment, with the caveat that we use these outlet procedures. But I think the mechanism of urinary bother is important in that. I think someone with just a fraught bladder with symptoms of irritative dysfunction, I think overactive bladder, I'm not thrilled about radiation for those patients. I don't think there's a good answer for patients with severe overactive bladder, but that's not fixable, and radiation is not going to improve that. As compared to an outlet obstruction bladder. It's never that pure, of course, as you know, but I think this was a better case for outlet. Certainly for brachytherapy, our institution will use a IPSS of 15 as a cutoff. I think you can make an argument for more permissive criteria than that, especially with alpha blockade, maybe optimizing it. But I just feel I'm a brachytherapist. I love brachytherapy. But we have a lot of options now. We have moderate hypertrophic SBRT, SIV. I just don't think it's a matter of 44-day versus brachytherapy anymore, where we have to force everything to a round hole. So that's just my take. I think Decipher arguably didn't change anything here. And you're right. We don't send Decipher a lot on high risk, honestly, at all here. We really only send on intermediate risk for the most part. In this case, I did it for academic purposes to kind of inform the GU9 protocol that maybe this patient merits would have merited the more intense. I think 0.85 was actually the cutoff in that protocol. So actually it would not be intensified. It would have to be de-intensified in that protocol.
That's right. I mean, I'm a huge fan of 009 and, Paul Lynn and Oliver's trial, because I do think that'll answer, first of all, de-intensification, intensification, but based on Decipher. I just think that most high-risk patients are going to be a Decipher high, and doesn't really give us anything. I had to go head-to-head with your colleague, Dr. Spratt, which is not an enviable task, and about biomarkers once in a couple settings, and was a discussion at ASCO GU on it. And I think that it's there out there. I mean, the 009 is going to answer a lot of those questions. The last question I had for the group, and you can go back one slide. In high risk disease, are you using space? Or, I mean, the question that I have, if you look at that, the two images before and after SpaceOAR, I mean, one asks the question, are some cells being left down on the rectum? If we truly feel that's EPE down there, and again, my feeling about the EPE by MRI is that the positive predictive value is not that great, although if the pretest probability is pretty high, like perhaps in this patient, it improves. So I think that this patient, if we feel like it's EPE down there, could we have left a few cells down on the rectum by putting SpaceOAR in a high-risk patient? What are people's thoughts on that? You can imagine that there might be some cells outside of your, lines there, or having lower dose on the rectum because of the SpaceOAR. And should we be putting SpaceOAR in men with high-risk disease that has possible extraprostatic extension at the posterior margins?
Yeah, I mean, this is a tough question to answer. So the original randomized trial looking at SpaceOAR didn't include patients who had extra capsular extension, but as Dr. Desai kind of mentioned previously when reviewing the MRI, sometimes we get radiologists calling capsular abutment as being possible ECE or suspicious for ECE, or, and so you get all of these vague terminologies, and we know that even when EPE is called on the MRI, it's probably only positive in about 50% of those cases. So, I approach these with caution. If it's just capsular abutment, I will consider doing a hydrogel. But if it looks like there's even suspicious EP, I'll often try to avoid it if I can.
Sure. Yeah, I mean, we put in the spacers, I put in my view, and I see, and surgically, I can see right between the fascial layers of Denavier's fascia, and I can just imagine, I've seen I mean, not seen, but grossly, it looks like it's invading in there, and I just ask myself whether I'm hurting them by putting hydrogel in there or not, by effectively elevating the main disease, but leaving microscopic disease that might eventually have issues.
And I'm of course conflicted because I have research funding and consulting with Boston Scientific, but I think we did have a phase 1 trial with high risk prostate cancer. So hopefully they all got spacer and we're just following them out. We'll find out that what you're saying though is absolutely true. There's a risk that we're underdosing that area. It's a trade-off. In this case, we got to heat up that area with very high doses because the spacer put the prostate off of the rectum. And so you can actually SIB it, which I'd be nervous to do without it. Conversely, you could leave microscopic cells, and like you said, a microscopic EP isn't hard to rule out. I think the two things that make me more comfortable in this case, I certainly wouldn't do it with someone with gross extrahepatic extension posteriorly. But a case like this, he did get neoadjuvant hormone therapy for 3 months. There's some degree of regression disease. Moreover, if you do spread microscopic cells around, you're still getting a low dose bath there that would be fairly equivalent to post-operative radiation doses for microscopic disease, and is getting hormones. So on the negative pessimistic side, we're not going to know. We may just actually get worse outcomes with presacral disease being flushed into the, into suprahemorrhoidals by saline. I have no idea. That freaks me out every now and then, and like, are we going to find this out in 7 years? And we may not know that for a long time. But I think, on the basis, the fact that we also do brachy for years, you would put needle through Gleason 9 out the back of the prostate to the seminal vesicles, and doesn't that spread disease everywhere? I think the fact that we don't have needles tracking disease into the rectum is always unique. I think it's possible, but I think it's a fairly low risk in a case like this. But I 100% agree with you. No, with gross disease posteriorly, I'm not putting a spacer back there.
Great.
I had a quick question for Dr. Lin. So oftentimes patients aren't exactly similar to this, where they are technically borderline for being surgical candidates. We'll see patients who are absolutely not surgical candidates because it's unsafe to put them under anesthesia, which limits the types of procedures that we can do to improve their outlet obstruction symptoms. So in those situations, do you have other procedures that you recommend, or is it move forward with radiation with the obstructive symptoms or nothing?
There are, emerging therapies, so that are a little bit easier, well tolerated, but they're usually a little bit bound by prostate volume. So I can tell you, I think on one of your slides there was something about a UroLift, and UroLift, technically, if one looks at the label and the packaging, it says that it has a limit of 70 to 75 cc's on a prostate. And so this one being 116 is sort of out of that zone. Have I seen people get them anyway? I have. And I think that actually can work. There's also other procedures that are being more minimally invasive. There's Resume, which again, some of them can be done either under spinal or even local blocks. And amazingly, patients tolerate it very well, especially some of these local blocks that they get no systemic anesthesia at all, barely sedation. And so, and we've had patients do that. So there are some other options. And again, you all, work with your urologic colleagues. We work very closely with ours. It's a really nice collaborative effort. So, so there are some options, but I hear you. It's really tough. I think that sometimes some patients end up just going forward with radiation and suffering a little bit, and post-operatively having retention issues.
Yeah, I'll say those are some of my more unhappy patients. So I was just curious. Thank you.
Great case.
Great. Yeah, I think those are all excellent points. I think we can go ahead and start moving on to the last case with Dr. Johnson.
Well, great. Well, there's some overlap between the first and a little bit of the second case, so hopefully we can get through quickly here. So the initial presentation here is this is a 68-year-old gentleman with an elevated PSA of nearly 23. He had a biopsy that showed that he had 4+5 prostate cancer in the left mid gland peripheral zone, and then there's also some 4+4 disease in the right apex and base. The MRI was done that showed he had a fairly large gland that was 65 cc's, and there were 2 PIRADS 5 lesions, one on the right and one in the left mid gland. The one on the right looked like there was some ECE as well as some seminal vesicle involvement. In terms of this patient's general history and physical, not a lot of terrible urinary symptoms. There's really no bowel or sexual function issues. Didn't have a strong family history of prostate cancer, no contraindications to radiation, and obviously no palpable nodular DRE that was noted. So, one of the questions that we have is, what do you recommend as further imaging and workup? This is not a poll question, but I just wanted you to think about it moving forward. So in the next slide, I'll show you here what was done. So the patient is kind of a standard workup, ended up getting a CT abdomen and pelvis and a bone scan. There was no evidence of metastatic disease. And then there's a PSMA scan that was done in this instance, and it showed some uptake in the right gland and a small focus within the left gland. These cross-sectional images here are demonstrating kind of this third bullet point, which is that there's some uptake in a left internal iliac node. If you look back on the multi-parametric MRI that was done, which is in this panel A, you would notice that there's this really small lymph node that's in the left internal iliac area. It measured 0.8 by 0.5 centimeters. With no really suspicious morphologic features. So it was there on the MRI. It wasn't really called because it didn't appear to be too suspicious, but on the PSMA scan, it clearly had some positive uptake. And then also, consider genetic testing. I hedged here given Dr. Lin's question earlier, which was, what are we really doing with this? But I specified that we'd be doing it mostly on protocol. And occasionally, although I didn't answer that question, when we do have a Decipher score in these settings, and men are really struggling with long-term hormone therapy, we will sometimes use that to adapt the duration of their hormone therapy and inform that discussion. Just another small piece of the puzzle. So the plan for the treatment here, and again, I'm just summarizing, we have a Gleason 4+5 prostate cancer with a PSA greater than 20. There's some seminal vesicle involvement in ECE on the MRI, and there now appears that there's clinical node positive disease on this PSMA PET. So the poll question is this: if the patient opts to proceed with surgery, what are the chances that they'd require adjuvant or salvage radiation within the next 5 to 10 years? Depending on your practice patterns, I could say, what are the chances that they would receive adjuvant radiation within the next 12 months? I tried to make pretty broad categories. So the chances that somebody like this would require adjuvant and salvage radiation within the next 5 to 10 years if they were to undergo surgery would be greater than 90%. In fact, even if you were to take the positive node out of the picture here, the chance that they would require salvage radiation within the next 5 to 10 years is probably between 80 and 90%, just with those features, the Gleason 4+5, the PSA of 22, and EC and seminal vesicle involvement. So again, sometimes this is not a bad choice for patients. We don't have a lot of high quality data to help guide decision making in this space, but it is something to consider. In advance, yeah. So because this is a radiation oncology panel, the patient decides to move forward with radiation. What radiation approach do you decide to choose? So I just chose the radiation approaches here for you. The systemic therapies we obviously addressed in the first case, but it's worth reemphasizing here in a second. But just for discussion's sake, what are these therapies that you would consider? So again, there's a lot of available options. I'm guessing based on the case that Dr. Desai just presented and the way that he treated that patient, that he probably selected a hypofrac with a focal boost. In these situations, the real challenge is that in a node positive setting, there's really no good data to suggest that brachytherapy boost should be used. Yeah, I didn't even talk about the nodal boosts in this situation, but you could choose to do dose escalated conventional fractionation or hypofractionated radiation plus or minus a boost, and then the brachytherapy boost is controversial in this setting. Next slide. So in terms of the radiation treatment plan, we decided to treat this patient with hypofractionated radiation therapy with Lupron and abiraterone. So these are the radiation details here. Most of you may recognize the hypofrac regimen of 70 gray and 28 fractions to the prostate, plus or minus seminal vesicles. And in our practice, we treat the elective pelvic nodes to 50.4 because it's a simple 1.8 per 1.8 gray per fraction over 28 fractions. We boost our nodes to a very high dose, and this is pretty aggressive. I recognize. And the reason for this 67.2 gray boost is that we're trying to get a EQD2 of about 75 gray into those nodes. And it's obviously there's a bunch of challenges with this, and I recognize that we have some pretty strict small bowel constraints, but we'll talk about that in just a second. As far as the systemic therapy details go, it's concurrent and adjuvant. The Abi and prednisone here we do for 2 years, and the Lupron we do for 3 years. And then as previously discussed, we would consider enrolling a patient like this on GU009. You could advance. It's just a treatment de-intensification or intensification using apalutamide stratified based on Decipher score. So the Stampede trial we've talked about in the first case, and this is an important trial, and there's some interesting nuances and caveats to this trial that I think people need to be aware of. And you can ignore, I guess, most of the written info here, but you should know that oftentimes people are eligible for this kind of treatment based on what's here in this green box. And so it's, if they're node positive, they're automatically eligible. If they have greater than, if they have 2 or more of these risk features, either stage T3 or T4, PSA greater than or equal to 40, or Gleason 8 through 10, then they are also eligible. So the things that you should know is that this T3 and T4 is not based on AJCC 8th edition staging, which is based on DRE, right? They enrolled patients, or they called these patients T3 or T4 based on their MRIs. And so that's just something to be aware of. And I think the other thing to pay attention to is that patients that are kind of in this orange box that are relapsing following a surgery or radiation, there's only 3% of patients on this nearly 2,000 patient trial that actually fit that category. So most medical oncologists, although I'm interested to hear Dr. Sokolova's thoughts on this, most patients aren't getting kind of Abi and ADT in like the post-prostatectomy setting following a biochemical recurrence. But again, practice patterns may vary. You can advance. So this was basically a trial that was comparing ADT and radiation as a standard of care, plus the addition of abiraterone plus or minus enzalutamide. As previously mentioned, the enzalutamide really showed no difference. So the benefit was shown in METS-free survival in the group that got ADT and abiraterone. And this translated into a nearly 10%, but it was a 9% overall survival difference when you're looking at the group of patients who got radiation, ADT, and abiraterone. You could advance. Side effects was already discussed, so we can skip this slide as well. So there are challenging aspects to this case. It's always challenging to have a discussion with patients about surgery versus radiation in these settings where we really lack high quality prospective randomized data. It's hard when it's unclear whether you're compounding side effects. It's not clear whether there's additional benefit to doing surgery followed by postoperative radiation, either adjuvantly or salvage. And so it's always a challenging discussion to have with patients. The other really interesting part of this is now we have novel imaging with new PET imaging modalities that can cause stage migration in the context of our already known data. So for example, many of the patients that were included in STAMPEDE, especially in that high risk group, may have also been node positive. It's not clear. Same with patients in the FLAME and the ACE and RT studies. In fact, one good example of this is approximately 48% of the patients that are in the ACE and RT study, which was a study comparing brachy boost to external beam alone with hormone therapy in unfavorable risk patients. That was basically unfavorable, intermediate risk, and high risk patients. Likely included many patients that would have been eligible for a STAMPEDE-like approach, and very likely may have had even some node positive disease. And so it's challenging to place these known studies in the context of new information. So basically this is when we're looking at FLAME and ACE and RT, when somebody has micrometastatic disease and we can see it in a lymph node, how beneficial is a local boost in that setting? It's really unclear. And then what do we do about boosting gross nodes? I will say this, all of the small bowel constraints that we have come from old data where we treated with 4-field, mostly 4-field. We do have some good data from 0529 and the GI setting using IMRT, but basically it's older data using radiosensitizing chemo, and the correlation with bowel toxicities is not clear. So we can treat pretty aggressively. Some people use a 54 gray max with a hypofractionated regimen. We will treat up to 62 gray max for our small bowel constraint and try to boost up to 67.2. And that's it for this case.
Great. Yeah, I think we'll open it up to questions now. We are right at 4 o'clock on the dot, but any questions in the chat or any questions related to this case in particular?
I think we have to mention the ongoing SVCG trial that's randomizing somehow 800 patients already randomized. It's amazing. Yeah. I wasn't even aware about this trial until about a couple of years ago. Surgery versus radiation, essentially, in terms of the local therapy. Hopefully some answers that we won't immediately say are irrelevant.
Yeah, we'll get the answers in 10 years when we're all doing something else already.
Mm-hmm.
So I think one aspect, how do you deal, Dr. Johnson, with nodes when you're boosting them? Do you have trouble aligning that as you're aligning the prostate? I feel like I've had that every now and then.
Yeah, so we do, and we've tried to take a hybrid approach with our IGRT instructions with our therapists, where we will obviously try to get them to do both, and where that becomes a challenge, we'll have them prioritize on odd and even days certain targets. It's a less than ideal approach, but that's the best way that we've discovered to approach it.
Yeah, I know Amar has talked about this, published a little piece on this. Apparently you need like huge margins. And I noticed this a while back when we were doing this. I think this has become more of an issue with the PET PSMA era, where we want to boost everything just like in head and neck.
Right.
Sorry, FT. I think, obviously if you have an adaptive machine, actually maybe some benefit to that. We've tried that, but you can't do that daily. It's not practical. Another thing that I thought of is, anyone who has Mosaic, there's a plan of the day feature. You can actually have like multiple plans you can load up on a daily basis. Now that's a big lift for the therapy side, but that was made for bladder. I think a lot of people did their bladder cancer in the UK. So you can actually have different plans depending on what the setups are. And I wonder if that can be integrated into making sure you actually can boost the node properly without having these 10 mm margins. But I agree, like 90% of the patients be fine. And like 10% of the patients, they're all over the place, and we adapt those daily.
Yeah, and in terms of like practical recommendations, we typically see that problem with people who have large amounts of bowel gas at the time of their simulation, where it's actually moved kind of the primary prostate target. And so we will, resim and resim and resim until we get, limited bowel gas, and we will do red tube catheters if we have to relieve that bowel gas as well.
Maybe for Dr. Sokolova and Dr. Lin, these patients, obviously we're talking about radiation quite a bit here. Is there emerging paradigms and perioperative systemic therapy where you're re-exploring roles of surgery in these areas?
I can answer real quick. A couple of things. Yeah, we have no idea what to do with these PSMA positive small nodes. We're learning a lot, and there's a stage migration, and Dr. Johnson really described that very well. And we're also learning about these distributions. I mean, this particular node is a low internal iliac node that we might not have removed at surgery. We're seeing perirectal nodes, rectal mesentery nodes, all these nodes in these PSMA scans that are not where we normally would go, not where we expect it to go. Obviously, with your radiotherapy planning, and it wouldn't necessarily be where you'd go either when you're boosting, pelvis or whatever. And so it's been a really instructive time in the last year or so. And we had a gallium program here for years, and so we've been trying to understand that more. As far as new paradigms, to answer your question, I think that there's a trial that's about to be launched, a multi-site trial that originated from Canada, but it will be using what Dr. Sokolova was talking about earlier, which is pre-operative genomics. And so if they do have a mutation, then it's a multi-arm trial. It's an umbrella trial that everybody gets put in an arm if they're MSI high, or if they're DDR mutation, or if they have other mutations, P10 or something like that, then they get put in arms based on their mutation neoadjuvantly, and the readout is a CR or near CR. And so we are going down that path of a genomically driven umbrella trial in which all patients are sequenced, germline and somatic, but mostly germline, and then they're put into their bin of where they will get a preoperative targeted therapy.
I would add also an ongoing clinical trial on kind of neoadjuvant ADT pre-prostatectomy. There is a trial by Marion Taplin. I think it's already ongoing and recently get activated, where they get 6 months of ADT plus AR targeted before prostatectomy. So I think there's a big interest in both academic field and pharma to move into this neoadjuvant pre-prostatectomy and see how we can intensify and improve outcomes.
All right, well, unfortunately, we are over time. I just want to say a big thank you to all of our panelists. And I think at this point, we can move to close.
Thanks so much.
Thank you, everybody. It was
Great.
a good time.
Great cases. Great case. Have a good weekend.
Thank you.
Thanks so much, guys.
Neil. Oh, he's gone.